Thank you for the kind introductions. My name is Boram from Seoul University Bundang Hospital. Good afternoon, distinguished colleague and the dear colleague. First of all, it's a great honor to be here at this joint symposium. Today, I'd like to talk about how we can better train and prepare the next generation of the surgeons. Nothing to disclose. When I first received these topics, I found it quite difficult. After thinking about it, I understood it as developing the next generation of robotics HBP surgeons from training to certification. Therefore, today I shared some thought from the junior surgeon's perspective. This is outline of my presentations. The first, I discussed the changing surgical environment, and then the limitation of traditional training system. Next, why the structured training program is important, especially for patient safety, and I will introduce a stepwise training approach method, and finally, I did talk about the data-driven training system and the certifications. As you saw on the slide, in this slide, the previous presentation of Professor Kwon, the robotic surgery in Korea has increased rapidly over time. In 2025, the largest proportion comes from the gynecology, followed by urology and general surgery. The robotic procedure in general surgery are also increasing. This shows that the 47% increase compared to the previous year. In 2025, in Korean, the HBP surgery accounts for the largest proportions. This slide shows the trend of robotic HBP surgery across Asia. Overall, the number of cases has increased in all countries, and China and Japan show the highest volume, and Korea also demonstrates consistent growth. We can see that the robotic surgery is increasing. This reflects the shift in the surgical paradigm. As shown in this here, the robotic surgery increased from about 2 to over the 15%. Meanwhile, the laparoscopic surgery remained relatively stable. This suggests that robotic surgery is become an important platform in robotic pancreatic surgery in modern surgery era. To better understand trend in our situations, I'd like to briefly introduce our collaboration study. This is joint consensus between Korea and Japan, and through this collaboration, we were able to summarize the current status and direction of minimally invasive pancreatic surgery. In Korean, the use of minimally invasive pancreatic surgery has steadily increased over time. As you can see, the use of robotic surgery has increased dramatically in Korea. The proportion of robotic cases shown in red has grown rapidly over time. And one of the key reasons for increasing robotic surgery is the change in the surgical workforce. In the past, the surgery was team-based and with stable support from the resident and assistant. However, recently in Korea, the surgical manpower has decreased. This is a real example from our current practice. Before 2024, the most surgery were performed with multiple assistants, including resident and surgical assistant. However, after 2024, the many procedures are now performed with only one single assistant. Because of this, some complex laparoscopic procedures are become too difficult to perform safely. For these reasons, we need a more stable and controllable surgical environment, and especially for junior surgeons, the robotic surgery is no longer a choice, it is required. To summarize, the surgical environment is changing. The robotic surgery is increasing, and while the manpower is decreasing. This affects the junior surgeon the most. So, robotic surgery is not optional anymore, it has become essential. Based on these changes, the training environment is also changes. So, it is important to understand why robotic surgery is difficult to learn. First, the opportunity to exposure depends on the center experience. In some centers, especially those focused on the laparoscopic surgery, exposure to robotic surgery can be limited. For example, our center has been a high-volume laparoscopic HBP surgery. Our robotic program started around 2018. For PD as well, the laparoscopic surgery started early, but robotic surgery began later, around 2018. Therefore, in my case, I had sufficient exposure to laparoscopic surgery, so I was already familiar with the laparoscopic surgery system, but when I started robotic surgery, there are many challenges starting from the team setup. With support my senior professor, Professor Yoon, in our centers, I had the opportunity to visit the high-volume robotics center, Severance Hospital, and learn from the Professor Choi. That experience provided a valuable exposure, especially in team setup and instrument setup, which was very helpful in the early phases of my robotic surgery. Another reason is that robotic surgery is not run step by step. In open and laparoscopic surgery, the trainee can learn side by side with immediate hands-on experience and tactile feedback. However, in robotic surgery, only one surgeon operates at the console, and trainee remains the bedside. So, it's not shared, hands-on learning is the environment. Robotic surgery lacks the step-by-step training. In open or laparoscopic surgery, the training starts with a simple procedure and progresses gradually. As shown here, in our centers, the laparoscopic training follows the clear pathway from cholecystectomy to distal pancreectomy or minor hepatectomy, and then to more complex procedures. However, in robotic surgery, cases are mainly complex from the beginning, such as PD or major hepatectomy. So, it is difficult to build up skills step by step. In summary, the robotic surgery is difficult to learn because it lacks a hands-on experience and step-by-step training. So, the traditional exposure alone is not enough. Given these challenges, the structured training program is very essential. And the most important reason is the patient safety. This study evaluates the outcome according to the learning curve in robotic PD. It is an international multi-center study including over 2,000 patients from the 80 centers. In the early phases, the complication rate was higher, including pancreatic fistula and major complications. In addition, this study shows that the mortality rate is still relatively high in the early phases. So, before overcoming the learning curve, the patient safety can be compromised. Therefore, we need structured training program to reduce the risk of complication. This is all my data. Using the moving average method and custom analysis, I am able to clearly identify the 3 phases of learning curve. This table shows the operative outcome. Regarding the POPF, in phase 1, the rate of clinical relevant POPF was notably high, reaching almost 32%. For the first cases, I used the posterior continuous ductal mucosa method for PG anastomosis. As you can see in this video, when I earlier experienced, I first complete the posterior continuous sutures and then proceed with the ductal mucosa part. Since this was the technique I used in open surgery, I naturally start with the same approach as my early robotic cases as well. However, there are 2 major issues with this technique. The first, after finishing the posterior continuous layer, it is become to identify the pancreatic duct, which made ductal mucosa suture quite challenging. And as mentioned earlier, the complication rate occurred in 35% of patients. Therefore, I felt that something needs to be changed. At the time, I contacted Professor Jaewoo at Assam Medical Center. I observed his operations. And after observing the all-interrupt method, the PJ technique, I subsequently adopt this method in my own practice. Fortunately, after adopting this technique, the rate of clinical relevant POPF markedly decreased, reaching only about 5% in the recent phase 3 phase. As shown here, after a structured training program and experience, the clinical outcomes improved significantly. This suggests that the proper training and guidance can directly improve the patient safety. Another reason for the necessity for structured program, we need a structured training program is the large variation in learning curve. As shown in this systematic review, the learning curve vary widely, and proficiency can require anywhere from 0 to 300 cases. This means that without the structured program, the training is inconsistent and unpredictable. In summary, the robotics learning curves are highly variable, and without standardization, the outcomes are inconsistent. More importantly, the early phases carries the high risk of complication after surgery. Therefore, the structured training program is essential for the patient safety. So how we can train? I tried to think about this question from a practical and real-world perspective. Let me start with the first approaches. The learning requires the sufficient exposure, but in robotic surgery, the real-world opportunities are limited. So one practical solution is curated video-based learning. Currently, our society website already provides expert video sessions. However, there are still limitations, especially in robotic surgery video content. In particular, there is a lack of step-by-step guidance and troubleshooting strategies and practical setup details. They are essential for the junior surgeons. The second approach is observership and visiting program. This allows training to gain the real-world exposure at the high-volume centers. Even short-term observership can provide a focused experience in specific procedure, like the robotic hepatectomy or robotic pancreatic surgery. Currently, our society already provides a structured training program. This included the inter-hospital program, hands-on workshop, and mentorship strategies. First, the inter-hospital program. This program is organized by the Korean Association of HBP Surgery, especially for support young surgeons. Through this program, the young surgeons were able to visit another hospital for 2 weeks and observe expert robotic surgery. The second program was the hands-on workshop offered by ITZY Korean Society. The strength of this program was that it allows me to actually perform surgery on the pig model under the supervision of experts. The society also offered the opportunity to visit overseas centers and observe surgery with the financial support. By watching their robotic surgery, I learned many new things. It helped me think again about my own technique, and I could improve it. This was very meaningful and valuable experience for me. I'd like to emphasize the importance of structured training programs supported by academic society. Although all these programs are valuable, I believe their impact differs depending on the stage of learning curve. Based on my personal experience, I try to organize them according to when they are most effective. In the early phase, the inter-hospital programs are most helpful. Later, after I learned the basic robotic skill, the hands-on workshop became more effective. The mentorship strategies was very helpful throughout the entire learning curve process. And finally, after I passed the initial learning curve, the international observership program gave me the new insight and inspiration. Now, I'd like to move on to the final topic, the mentorship strategies. Among all training strategies, I believe the mentorship is the most critical element in the robotic surgery training program. To support this idea, I'd like to introduce a recent systematic review and meta-analysis of robotic pancreatic surgery training program. This study evaluated over 2,500 cases and specially analyzed the impact of mentorship on the learning curve. The key component of effective mentorship program included direct mentor environment during the early cases, as well as structured video-based feedback. In addition, the simulation-based training and dry lab practice can further enhance the learning process. Importantly, the mentorship program was associated with significantly improved outcome of the early phases of surgeons. The surgeon achieved proficiency about 13 to 14% faster, while the complication rate and conversion rate are reduced. And ultimately, the lead to better patient safety and even improve the system efficiency. There are two important findings here. First, the mentorship shows a clear dose-response relationship. Especially after around 10 mentored cases, we see the meaningful improvement in operation time and complication and progression to autonomy. Second, the mentor experiences also play the critical role. The trainee, guided by high-volume mentors, had a lower complication rate and reached autonomy faster. In my personal experience, the mentorship program became one of the most meaningful experiences in my robotic PD surgery. The Professor Jaewoo at Asan Medical Center supported me during this time. He reviewed my surgical video and gave detailed feedback and even shared his own cases to help me improve. And he also provided the teaching and valuable education opportunity for our nursing staff. This style of communication really helped me to overcome the learning curve. In summary, the training must be intentional and it should be structured and staged and mentored. The training should not be left to chance. Finally, I'd like to briefly introduce the data-driven education and certification system. Current training is still rely heavily on case volume and subjective evaluation, leading to significant variability between surgeons. Importantly, the surgical difficulty and patient risk are not adequately reflected in current system. With data-driven approaches, we can objectively assess the difficulty, predict the risk, and evaluate the performance. To address this issue, we are currently developing data-driven training models. The robotic PD is increasing worldwide, but it remains technically demanding with a substantial learning curve. Importantly, the early learning curve phases is associated with a higher complication rate. Therefore, the improved performance during the initial phase is critical for the safe adoption of robotic pancreatic surgery. Therefore, to improve performance during the early learning curve phase, we designed this study to develop a structured and difficulty-based training model for the robotic pancreatic duodenectomy. This is our study design. We first developed the AI-based model using preoperative variable to predict the surgical difficulty. This model estimates the complication risk and generates a probability-based difficulty score. Based on this score, the patient was stratified into low, intermediate, and high-risk groups, and the learning curve was analyzed within each stratum. The learning curve analyzed alone is not sufficient, as operation time does not necessarily reflect the clinical safety. Therefore, we introduced the outcome-based threshold, identify the point at which key clinical outcome becomes stable. This threshold better reflects the true clinical safety and can guide objective and stepwise training progressions. The key step of this study is defining the progression criteria by integrating both learning curve and the outcome-based threshold. The progression is not determined by case volume alone, but requires both technical proficiency and acceptable clinical outcomes. In practice, the trainee passes each progression gate only when the predefined criteria, such as stable outcome below the target threshold, are met. This enables a structured and difficulty-based training pathway. Based on this framework, we are developing stepwise and structured training models. The trainee progress from low to high difficulty cases through clearly defined the progression gate, which require both technical proficiency and stable clinical outcomes. Currently, we are analyzing AI-based difficulty score, and we expect to present the finalized structured training pathway by the end of this year. We expect that this structured data-driven framework could be extended to future certification systems. In summary, the robotic surgery is rapidly expanding, but it remains difficult to learn. The main challenges are limited hands-on exposure and the lack of stepwise training. Without a structured program, the learning curve varies widely and patient safety can be compromised. Therefore, the training should not be left to chance. It must be structured and staged and supported by effective mentorships. Thank you for your attention.
Good afternoon, everyone. I'm Seok-Hwan Kim from Chungnam National University Hospital. Thank you for the kind introduction. Today, I will talk about how to build a robotic HBP program in real clinical practice, focusing on institutional pathways and team integration. I have nothing to disclose, and picture taking is allowed. Today, I would like to talk about a very practical question, not simply why robotic HBP surgery is attractive, but how we actually build a robotic HBP program in the real world. In my view, the field is moving beyond a discussion of technical feasibility. We are now entering a phase in which institutional readiness, team integration, and financial sustainability determine whether a program succeeds or fails. So my focus today is not only the robot itself, but the institutional pathways required to establish a safe, scalable, and reproducible robotic HBP program. The reason robotic platforms matter in HBP surgery is that their technical advantages are directly linked to clinical value. Three-dimensional magnified vision improves identification of critical vascular and biliary structures. Wristed instruments allow precise dissection and steering in narrow and deep operative fields. Tremor filtration and better ergonomics become particularly relevant in long and complex operations. Importantly, these technical advantages are not merely cosmetic. In selected procedures, robotic surgery has shown lower blood loss and shorter length of stay while maintaining acceptable oncologic and surgical safety. So the question is no longer whether robotics can work in HBP surgery, but how to implement it responsibly. I would like to frame program development in three phases: adoption, operationalization, and standardization. Phase one is about governance, feasibility, capital investment, and assembling the core team. Phase two is about safe clinical and trial, learning curve management, and prospective outcome monitoring. Phase three is about building stable systems, standard operating procedures, credentialing, cost efficiency, and the capacity to train others independently. This staged approach is important because robotic HBP surgery should not be introduced as an isolated technical initiative. It must evolve as an institutional program. In the adoption phase, the first priority is governance. A robotic steering committee is essential, including surgical leadership, anesthesia, nursing, and operational coordinator. Second, there must be a realistic market and feasibility analysis. Case volume, interdepartmental sharing, and return on investment should be examined early. Third, infrastructure matters. A robot purchase alone is not enough. Operating room layout, inventory storage, and block time allocation all need to be prepared. Finally, the human component is critical. If possible, recruitment should prioritize surgeons who already have strong HBP expertise and prior robotic exposure. The key message is simple: robotic program starts with systems, not with enthusiasm alone. Once the platform is introduced, the challenge shifts to safe operationalization. The learning curve should be managed in a stepwise manner. In the earliest phase, expert proctoring is essential, and case selection should be conservative, typically patients with lower technical complexity. In the intermediate phase, index procedures such as robotic cholecystectomy, distal pancreatectomy for selected benign disease, and minor liver resections can help stabilize workflow and operative time. Only after the team has gained sufficient procedural familiarity should major hepatectomy, robotic Whipple procedures, or biliary reconstruction be attempted. This is also the phase in which institutions must protect surgeons from productivity pressure, because patient safety should never compete with short-term financial expectations. One of the most practical safety strategies in early robotic HBP implementation is the two-attending approach. The console surgeon focuses on dissection, steering, camera control, and procedural flow. Meanwhile, the bedside attending acts as a true safety guardian, managing inflow control, suction, stapling, clip application, and immediate response to bleeding or conversion. This model improves decision-making, shortens response time during emergencies, and provides an important psychological safety net for the team. In HBP surgery, where major bleeding or technical failure can escalate quickly, the bedside attending is not just an assistant. This role is part of the safety architecture of the program. At the beginning of the program, the institutional mindset should be one of intensive investment for safe establishment. During this period, maintaining a double attending model may appear expensive, but in reality, it can prevent far greater losses associated with conversion, complications, or prolonged operative inefficiency. As the program matures and workflow becomes standardized, roles can gradually be delegated. The bedside role may transition to highly trained fellows, physician assistants, or specialized coordinators. So the goal is not to keep the same structure forever, but to move from high-intensity support toward efficient, standardized team performance. For regional centers, the main challenge is often volume rather than motivation. In this setting, success depends on prioritizing system safety over individual speed. The first two attending strategies in the first 30 to 50 cases can help maintain a zero-incident culture. Second, hub and spoke telementoring can connect regional hospitals to high-volume centers for remote proctoring and structured video review. Third, interdisciplinary platform sharing with urology or gynecology is often essential to justify the capital investment and maintain high utilization. Regional hospitals do not need to imitate high-volume centers in scale. They need to replicate the logic of safe escalation. In phase 3, the program must move from individual competence to institutional reliability. This requires detailed standard operating procedures for docking, instrument exchange, emergency undocking, and conversion processes. Credentialing and privileging should also be formalized, including simulator training, wet lab, or cadaveric exposure, proctored cases, and minimum annual volume requirements. At the same time, cost optimization becomes increasingly important. Lean workflow design, careful monitoring of instrument life cycles, and efficient scheduling across services all help reduce per case cost. Standardization is what transforms a promising program into a sustainable one. To evaluate a robotic HBP program properly, we need more than operative anecdotes. A balanced scorecard allows us to track performance across 4 domains: finance, patient outcomes, internal process, and learning. Financially, we should monitor consumable cost, utilization, and instrument turnover. From the patient perspective, length of stay, readmission, and complication profiles remain central. Process metrics include operative time, docking time, and conversion rate. Finally, learning metrics should include simulation hours, resident console participation, and proctored events. If we only measure case volume, we miss the true health of the problem. A successful robotic HBP program is fundamentally multidisciplinary. The console surgeon leads the technical execution, but the bedside assistant manages critical patient side tasks. The scrum nurse must anticipate instrument needs to maintain sterility and instrument life awareness. The circulating nurse coordinates room flow and troubleshooting. The anesthesiologist safeguards physiologic stability, which is especially important in liver resection and prolonged pneumoperitoneum. And finally, the robotic coordinator aligns logistics, inventory, scheduling, and compliance. When these roles are clearly defined, the robotic becomes a platform for team performance rather than a burden on the operating room. In robotic surgery, non-technical skills are not secondary, they are critical for patient safety. Because the console surgeon is physically separated from the patient, situational awareness must be actively maintained through audio cues and deliberate team communication. Leadership must be explicit, but nonverbal cues are reduced. Flow disruptions, such as arm collision, cable interference, or delayed instrument exchange, must be anticipated and prevented with checklists. For this reason, robotic surgery demands a different communication culture. Technical skill alone is insufficient if team cognition and coordination are weak. One simple but powerful safety tool is closed-loop communication. In robotic surgery, the surgeon's command must be clearly stated. that the request must be read back by the assistant, and task completion must be confirmed. For example, if the console surgeon asks for a hemlock clip, the bedside assistant should verbally confirm readiness and then quickly confirm that the clip has been secured. This reduces ambiguity, prevents delay, and lowers cognitive load during critical steps such as vascular control, energy activation, docking, or instrument exchange. In other words, communication itself becomes an operative instrument. Simulation-based team training is one of the most effective ways to build a robotic safety culture. The purpose is not only to train surgeons, but to train the entire team together: surgeons, anesthesiologists, nurses, and support staff. Emergency undocking drills are especially important for events such as a major hemorrhage or cardiac arrest. These scenarios should be practiced repeatedly until the team can undock and respond within a target time of roughly 60 to 90 seconds. Regular simulation also helps identify latent safety threats before they appear in real patients. This is how teams move from theoretical readiness to operational readiness. The robotic coordinator is often underestimated, but this role can become the operational engine of the program. The coordinator synchronizes scheduling across services, manages inventory, tracks instrument lives, maintains surgeons' preference cards, and monitors credentialing status. In practical terms, this reduces friction in the operating room. It improves turnover time, prevents avoidable cancellation, and minimizes setup variability. When a robotic program struggles, the reason is often not the surgeon's technical ability, but failure in process management. That is why I believe the coordinator functions as the control tower of the entire system. From an administrative perspective, the robotic coordinator should not be viewed as an overhead expense. Instead, this is a high-yield operational investment. Programs often focus heavily on the hardware, but neglect the process infrastructure required to use that hardware efficiently. A strong coordinator can improve utilization, reduce setup variation, shorten turnover time, and lower waste related to inventory and instruments. As a result, case volume can grow more predictably, and the path to break even becomes shorter. So when we make the business case for robotic HBP surgery, we should present the coordinator as a value-generating role, not as optional staffing. This slide summarizes a realistic roadmap for regional center. In the first 6 months, the focus should be on foundation building through benign cases and minor resections while optimizing SOPs and team workflow. In the next phase, more advanced procedures such as segmentectomy and distal pancreatectomy allow development of dissection and suturing skills. These cases often serve as the bridge to more complex surgery. Only after the progression should the program move toward robotic Whipple procedures or major hepatectomy. The key lesson is that regional success depends on disciplined escalation. At the society level, we should broaden our educational focus beyond surgeons alone. Beside assistants, scrum nurses, and robotic coordinators all manage risk-sensitive steps, including docking, troubleshooting, and emergency undocking. Their training should be formal, structured, and standardized. This is where societies such as KSERS or KHBPS can make a major contribution through standardized curricula, joint simulation courses, and certification pathways for robotics associates. If we truly want to scale safe robotic HBP surgery, we need to professionalize the entire ecosystem, not just the surgeon's console skills. The published literature, including both international and Korean experiences, support several consistent messages. First, structured program launch can be achieved safely when case selection and team development are organized appropriately. Second, high-volume experience shows that robotic HBP surgery can maintain strong oncologic safety with low mortality in selected settings. Third, meta-analytic data for robotic pancreatic duodenectomy suggests that key post-operative outcomes, including major pancreatic fistula and delayed gastric emptying, are generally not inferior to open surgery, while minimally invasive recovery benefits may be preserved. However, the most important conclusion is these outcomes are program-dependent. Technology alone does not guarantee safety. System quality does. To conclude, I would emphasize four messages. First, institutional commitment is essential, including governance and a dedicated coordinator. Second, the learning curve must be respected through stepwise case escalation and proctoring. Third, team integration, especially the two attending model and simulation-based non-technical training, is a major safety lever. And fourth, programs should be monitored with data across clinical, financial, and operational domains. Ultimately, successful adoption of robotic HBP surgery requires a shift in mindset from individual technical skills to system competence. This is our programs for residents. We using mini-pig and laparoscopic devices. We make the resident much familiar with MIS. And this is surgical video training. We watch surgical video with PAs and SAs and scrum nurses. So I explain them why I do something at this point, and so I need a special device, and then they can understand much more than the operation, and they can anticipate the device, so they can minimize the delay instrument exchanges. Thank you for your attention.